Good morning, everyone. My name's Kerry Bygrave. I'm a consultant haematologist and I'm the clinical lead for myeloma at UHW in Cardiff. Thank you for joining me this morning. I'm here to talk to you about a project called Haemato Cymru and how that has led to the development of the Wales National Myeloma Dashboard, which is a really valuable resource for patients and clinicians with myeloma in Wales because it's helped us to measure the impact of myeloma care. Next slide, please. So just to give you some background about where this project came from, Haemato Cymru was founded as a joint working agreement between the Wales Cancer Network, Cardiff and Vale Health Board, Welsh Government and Janssen Pharmaceuticals, and the original agreement was signed back in 2018. And the idea was to find a way for all these parties to work together to try and achieve something that would give real value back to patients with blood cancers and to prove the principle of joint working. And when we started talking about what we might do, if we could do anything in a project like this, as the clinical lead, the first thing that came to mind was data. Because ever since I was a medical student, I've been struck at the very poor quality of data that we have available about our patients. Starting from the point that many of us still make clinical notes on paper and file them in paper records, and those records get pushed around the hospital in trolleys. This is something that I still find very difficult to believe in 2021. So the idea of setting up Haemato was to achieve better quality data and analytics in blood cancers. And mainly because I was the clinical lead and my specialty is myeloma, we started with multiple myeloma, although I have to say it is the second most common blood cancer. So if we can get the principles right here, we could potentially roll it out to lots of other patients. So after a consultation period and lots of meetings with technical people, with a whole multi-stakeholder arrangement, the project finally went live in December 2019. Sorry, to December 2019. And what we did then was launch the outpatient continuation sheet, which is an e-form that's embedded within the Welsh Clinical Portal. And we now use that to capture the clinical narrative. And what that means is that every time we see a patient in clinic, their data is captured instantly and it's stored somewhere. And if you imagine, every time you're making notes on paper, that's not happening. That data is just sitting in a file somewhere in a storeroom. But by using an e-form, we have the clinical narrative to hand. The minute the patient walks out of the room, it's saved. And so there's a greater transparency about what's going on because anybody in any hospital in Wales that uses Welsh Portal could potentially access those records. But also because the form had been designed to capture structured data, that data can be quantified, it can be stored, it can be analysed, and then it can be put to use elsewhere. So following on from the outpatient continuation sheet, we then launched a myeloma-specific MDT form in 2021, and that is now used in our MDTs to capture all the diagnostic and staging information. This data now combines with many other sources to feed into the National Myeloma Dashboard. And the Haemato team are very grateful to the Value in Health team for actually choosing myeloma as only the second cancer to launch its dashboard. So I believe lung cancer was done first, but shortly after that we followed up with myeloma. So this presentation will describe the journey and focus on the dashboard as an output to measure value in blood cancer care. Next slide, please. So just a quick summary of what myeloma is. I'm sure many people in the audience will know, but potentially some will not know at all. So myeloma is an incurable chronic blood cancer. The median survival is now 7 to 10 years from diagnosis. So even though when you're diagnosed, unfortunately, we can't tell people we can cure them, it is a cancer that people can live with for a long time. And what that means from a patient point of view is many visits to clinic. Many visits to the day unit to have treatment, many follow-up phone calls with nurse specialists, and all of that is actually a source of data. That's telling us how the patient is getting on. And if we do it right and we capture PROMs, that's telling us how the patient is feeling while they're on treatment. But all that data is important, it's all relevant, and it all needs to be analysed in the context of everything else. And so what we try to set up with the dashboard and with Haemabase is a way to analyse all of that data at the same time. The other thing about myeloma is that most patients are elderly because the median age at diagnosis is 69 years. And also because it's a chronic blood cancer, unfortunately, many people require long-term maintenance chemotherapy. And what that means is if you're on chemo for a long time, and that can be several years, there's a high risk of toxicity from treatment. Also because people are elderly and they have other diseases like diabetes, high blood pressure, etc. There's a risk of drug interaction with other medication they're on. And also there is a risk that by treating the myeloma, we might actually worsen some comorbidities or vice versa. So all of that data is important. Having myeloma and diabetes is not the same as having myeloma and not having diabetes, for example. But we need a system that can capture that and give us a snapshot of what patients actually look like. And so if they do well, we can be proud of the achievement and think about why they do well. But if patients do badly and they don't respond so well to treatment, we can look for other confounding factors that may have led to that. The other thing about myeloma is that the cost of treatment is extremely high. So £2 in every £5 that NHS England spends on cancer drugs goes on myeloma. That is an eye-watering statistic. But perhaps what's more eye-watering is that clinicians like me are allowed to prescribe these treatments, provided they're NICE approved, and there is no real national system for demonstrating value. There's no national system to say, okay, that money was worth spending. Those patients benefited. Those patients had a better quality of life. Those didn't. That treatment is worth backing. That one isn't. So that's what we're trying to do. There was no good data on myeloma care prior to Haemabase, and there was no means to assess the impact of treatment either on patient longevity, so did it make them live longer, but also, and more importantly, on their quality of life. Next slide. So why was this? I mean, I've touched on this already, but a huge factor was, and still is, in other aspects of haematology and medicine, the reliance on paper record keeping, because that narrative, that record of what's going on is not available. And that means there's no ability to track activity in the clinical setting. There's no means to analyse data that was captured either on a per health board basis or on a national basis. And I think what we find is that historically the NHS is very good at working. We've achieved a lot. There's many things that we can do. We can treat patients, but we have been less good at asking ourselves, why does it work the way it does? And actually whether the work that we do is worthwhile. And that measuring value, measuring impact is all about this discussion this morning. The other thing is that up until now, we've not been very good at collecting patient level data from PROMs, and we haven't been able to use that data to make a treatment decision. But potentially it's as important or even more important than whether or not a patient is responding in terms of their blood tests, because if they feel terrible, we should be stopping the treatment. Next slide, please. So myeloma has been through a massive evolution. If you just click. In the past, we basically treated everybody the same with very simple drugs, cyclophosphamide, steroids, that's all we had. And it wasn't really surprising that people didn't live very long. Presently, if you just click, we have trials available that are actually risk adapted. So we can stratify treatment depending on what patients look like at the beginning, or potentially how they respond to treatment, if you click. But in the future, actually what we'll be doing is looking at patients really deeply at a molecular level, at a genetic level, and saying, okay, this person actually has this type of myeloma and they would respond better to this type of treatment or feel better on this type of treatment. Whereas this person has a different type of myeloma and they need this kind of treatment. We will never be able to do that without good data. Next slide. So the OCS has definitely changed things. We're now able to capture structured data in real time. And that generates a live data set for us of everybody who's under investigation and treatment. Also, the MDT form captures the diagnostics, the staging, the treatment plan, supportive care, referral to other services. So you really get a 360-degree round view of what's going on with this patient's treatment. And that gives us the footprint for myeloma care. And there's also sections within the OCS for comorbidities, performance status, etc., that adds to that 3D view of the patient. Next slide. So on these slides, I'm just going to show you some images, firstly, of what the OCS or the outpatient continuation sheet looks like. So this is an e-form, an electronic form that is available within the document section of Welsh Clinical Portal every time a patient has an appointment in one of the myeloma clinics. So we have 5 myeloma clinics in UHW and multiple users of the form. And every time a patient comes for an appointment, all you need to do is open up the form on Welsh Portal and basically start typing. You can see that it's been set up so that you can toggle different sections on and off, where you see a blue dot with a white circle in the middle. If you clicked that, that section of the form would disappear. And so what that means is that you don't have to keep collecting information that is not relevant for a follow-up review, for example, such as adverse reactions. You might collect it once at the beginning, but you don't need to keep doing it over and over again. The data is structured in that if you look at the presenting complaint bar and you see where it says cough, that has been linked to SNOMED coding. So when you type in cough, the SNOMED dictionary will flash up and you click it. And then that gets coded as cough, so that when you come back and analyze the data, basically it's the same all around the world. It's the same code, and that means that that data is cross-comparable. And then the rest of it is set up as per a history that anybody would be taught to take in medical school. So you have presenting complaint, past medical history, drug history, etc., social history. Examination, obviously, if you have the patient in front of you, you can examine them and you can document all of that. And at the top, there's a really important section for observations, which is things like height and weight, blood pressure, smoking, alcohol, and perhaps for me as a cancer clinician, performance status or exercise tolerance. Those are the bits that actually I like to fill in first because it has huge relevance to treatment decisions. Next slide. So just going down, this is just a little bit more detail about the lower sections of the form. And then at the end, there's a section for investigations. And what we do at the moment is we copy the blood results from the tests section of Welsh Portal and we paste them in. We are looking to update the OCS so that those results are instantly imported, but that functionality isn't available yet. And then there's sections for action plan, for information given to the patient, and then for a clinical summary at the bottom, and then you input your password and save it, and the form is instantly available. You can also edit the form for 24 hours after the appointment, and then following that, it is saved as it is. Next slide. The MDT form, if you're not a myeloma specialist, this will be quite overwhelming because it was designed by people who are myeloma specialists who want to know every little detail about the disease. So for someone like me and Andy, who you'll meet in a second, it's great. But otherwise, I'm sorry if it's a little bit too detailed. But essentially, it's set up like any MDT. So at the top, you've got the meeting name, the date, the MDT lead, the organisation where the MDT is taking place. Excuse me. A lower section for clinical history. And then we scroll through the staging system for myeloma, which is the ISS stage, revised ISS, genetics, plasma cell percentage, etc. Next slide. In the middle of the form, there's some really key bits of data. So particularly around the symptoms, do the blood results show evidence of a myeloma defining event? That's really key data, because if you go back in 2 years' time and say, well, why did we start treatment on this person? And you have a data point that says because they're anemic, or they broke a bone, or they had kidney failure. Those are hard bits of info that are very easy to collate and analyse. But before we had a form like this, it was much harder to capture them. If you type them into white space on a conventional PDF document, that data is not analysable further down the line without manual work, basically. Next slide. And then at the bottom, you've got lots of sections on the cancer care plan, who's the responsible clinician, what treatment has been selected, chemotherapy? Are they in a trial? Who's their key worker? And then a big section on supportive care, because supportive care is a big aspect of myeloma. Next slide. So what we're going to move on to now is a live demonstration of the National Myeloma Dashboard. And like I say, this came about after Haemabase had been up and running for quite a while, to say, okay, now we're collecting data, where can we pull it all together? Because it's no good collecting it if you don't do anything with it and you don't present any of the figures and the stats. So as I said before, very kindly, the Value and Health team, particularly Dr. Sally Lewis and her team, took it upon themselves to help us with this project. The software has been built using Power BI, and the aim is to present data on myeloma care in Wales. So although the OCS and the MDT form currently is only available in Cardiff and Vale, the national dashboard really is a national dashboard because the OCS and the MDT data are only two of the data resources that have been used in order to develop the dashboard. So here you can see a list of all the other data sources that have been used to put it together. So that includes CANISC, admitted patient care, emergency department data, ONS, etc., etc. Next slide. And so here it is. It's available via a link through Power BI. And I'm going to hand over to my colleague Andy Simmons now, who's our data analyst for Haemabase Cymru. And he's going to walk you through a bit of a demo as to how the dashboard works.
Thanks, Kerry. I'll just load up the dashboard now. Okay, hopefully that's presenting to everybody. So yes, good morning, everybody. My name's Andy Simmons. I'm a data analyst for the Haemabase Cymru team and also for Cardiff and Vale Haematology. And here is the National Myeloma Dashboard. So if we skip into the contents. So here's our overview and explainer of the contents of the dashboard, and it's also another means to access the different sections, but it also gives us a little bit of an explainer about what each section is doing inside the dashboard. And whilst Kerry has already explained about the data sources, I think it is worth reiterating to show the range of sources that the value-based healthcare team have pulled together to make this dashboard a possibility. I don't think many of these would be readily available to someone like myself. So the dashboard is already proving to be a really valuable resource for a lot of our work, both for myself personally and for the myeloma team. If we skip across into our myeloma summary statistics board, you'll please excuse the slow load up. That's more my old PC rather than the system itself. So we've got an anonymous version of the data here for the purposes of this presentation. But as with the other dashboards developed by the Value and Health team, we've got dynamic information and tables here showing the myeloma data, and we've got a range of filters available to filter down the information to show what we want to see. For myself, I can extract the data from here, and I can also get these diagrams into presentations. So if I want to show off how well we're doing, then I can do so, luckily with these lovely diagrams that the dashboard is able to produce. So here we've got a glance overview of our key myeloma data points, cases per annum by sex, the amount of admissions and patient deaths. As Kerry said before in the presentation, our main patient cohort range is 65 years plus, median age 69 years for myeloma diagnoses. And of course, that's significant in a aging population in Wales. So another positive with being able to extract all of this data from a range of sources is to answer questions that have come up, especially in the advent of the global pandemic. So this piece of work here was driven by the suspicion that there had been a pandemic-related reduction in patient attendance into hospital. So we asked the Value and Healthcare team to see if we could pull the information to see how many of our patients were still attending hospital. So they've given us a true picture of patient attendance, and you can see this is for all health boards across Wales, but you can see a very fluctuant picture especially with their change in clinical practices to adjust to the pandemic. But in particular interest was the reduction in new cases diagnosed, most likely with patients still being unwell. They may have been more reluctant to attend primary and secondary care settings during the pandemic. And I think before the development of the dashboard, this would certainly be very hard to prove this or to show this in such a clear way as before. In our planned admission section, we can dive even deeper into the data and look at chemotherapy admissions. Yes, so we can look into those patients who are attending hospital specifically for treatment or for other procedures. The only limitations with this is a lot of this data is from CANISC, and so it would only highlight whether a patient has had chemotherapy or not had chemotherapy, whereas, as we'll go on to shortly, the future will hopefully show us that we can get more detail on this area in the future. If we move on to myeloma in the population, we've got a 5-year average of myeloma diagnosis in Wales by a health board, and then we can also look at diagnoses by deprivation as well as a more general outlook, a general picture about myeloma in Wales. If we move on to survival statistics, which is also from CANISC data, and this is divided into 30-day, 1-year, 5-year and 10-year sections. This highlights the prognosis when treating myeloma patients and the challenges faced by Kerry and the other clinicians in the face of an incurable malignant disease. We can, again, using the filters, split by health board, age and sex, and whether treated by chemotherapy. And again, because this is CANISC data, unfortunately, we've only got chemo or non-chemo options. Yes, this is the areas where the individual health boards in Wales are split into these 6 different visualizations. And moving on, we've got the 5-year survival data for those treated by chemotherapy. So it's all really clear, really dynamic forms, which we can adjust with the filters on the side to show us different areas, different years, different patient groups. And were this not on my computer here in the office, it's certainly more slick and smooth, and it's a really good resource for myself. The final section shows us a snapshot of some of the outpatient continuation sheet data that we've been collecting since the advent of the new eForm on Works Clinical Portal that Kerry and our team has been using in clinic. And immediately it shows the difference between the legacy CANISC data, for example, and the newer outpatient continuation sheet data sets. And it also highlights the potential for future iterations of the dashboard and the importance of our ongoing digital transformation services. We've got an increased level of patient-specific detail thanks to the structured data items in the outpatient continuation sheet form. This will only aid better analysis for folks like myself. We can delve deeper into individual patients. It'll help drive patient care, specific care plans for these patients, and it concurrently will help drive further improvement in outcomes for our patients as well. And as Kerry has said, the myeloma MDT form, it's also another key resource moving forward, as it's catching the key data points for each of our myeloma cases at diagnosis in a depth that just wasn't previously possible. We're very grateful to the Value in Healthcare team for taking on this project and helping us to achieve this, and also the collaborative work is only going to aid in positive outcomes for our patients. That's the National Myeloma Dashboard.
Thank you, Andy. That was great. If we can just go back to my slides. So that was obviously a really nice demonstration, and it makes me smile to see it up in lights. It's a really useful resource for us, and it certainly helps put myeloma on the map and shows what a project like this can achieve. In terms of the future, obviously, we're not happy with it as it is. We want to keep moving forward. Some of the key aims are for greater integration of treatment data, particularly from ChemoCare, which is an electronic prescribing module that is used all over Wales. So as Andy said, using the data from Canisc, you get some very crude information about whether a patient is on treatment or not. And that's useful. That's definitely better than nothing. But once we get a data feed from ChemoCare, we'll be able to blend in different types of treatment. So regimen A, regimen B, regimen C. And then we can look at survival, and then we can look at quality of life and really drill down into the statistics to see which regimes work better for whom, and where there are gaps or problems that we need to work around clinically. And that will allow us to basically measure the success in quotes of treatment, so longevity and quality of life. Also, one of the problems in myeloma, because it's a chronic cancer, sometimes it's difficult how to sequence treatment. So if you have options, should I give A or B next? Is A better than B? Does it depend what you had before? Does it depend how old you are? Does it depend what comorbidities you have? All of those are really complicated problems, and the only way to solve them is with more data. So what to give to whom and when to treat people for relapse. Should we treat them as soon as the bloods start going off, or should we wait till they've got treatment, they've got symptoms? We need data to support those kind of decisions. There's some other really interesting pieces of work that we'll be able to do with more data. So there are still inequalities in outcomes between different social and economic groups, particularly in myeloma, because myeloma is a cancer that actually particularly targets people of non-Caucasian, particularly Afro-Caribbean background. They usually get myeloma at a younger age, and it can be more aggressive. And we also know that people from non-Caucasian backgrounds are actually more likely to not take part in clinical trials. They're less likely to take up the opportunity to participate in research. And the reasons for that aren't fully understood. But again, that is a piece of work which something like a dashboard could help support by bringing together all of the data that you need. We also need to integrate existing data with PROMs. And we're almost at the point of capturing PROMs electronically in Cardiff and Vale. And then we can feed that data through to the dashboard. And obviously that will tell us how quality of life changes throughout a patient's journey. And probably there are other endpoints that we're not currently measuring that can really help us define whether or not people are doing well. We need to get more PPI, more patient public engagement, so that we can find out what's important to patients, and obviously capture that data and present it somewhere centrally. Next slide. So thank you all for your attention. Hopefully that has been self-explanatory, but if there are any questions, please don't hesitate to send them through. And what I'm going to do now is do my best to answer the questions that have come through in the chat, because there are quite a few. So the first one, are there any plans to expand the OCS to other conditions or cancers? The short answer is yes. The main source of that is the Cancer Informatics Solution, which is being organised by Digital Health and Care Research Wales. And that has been going for a number of years, started really before Haemabase. And the idea in simple terms is a replacement for Canisc. But there are lots of aspects to the CIS, and they include everything from e-forms and collecting data to chemotherapy and prescribing, national audit, all of those things. So that work is ongoing, but one of the key goals of the Cancer Informatics Solution is a version of the OCS, excuse me, to be available within solid tumours and other aspects of haematology, and the timelines for that are quite imminent. The next question is, how come the OCS data is only from Cardiff? What is the main challenge to expanding its use to other health boards? Wow, that's a big topic that I won't be able to cover off in the next 10 minutes. But essentially, it started with Cardiff because Cardiff were a signatory on the original joint working agreement. And so we were the first health board. Haemabase, from the beginning, was always meant to be a national project. Excuse me. So we had lots of collaboration from stakeholders from other health boards. Excuse me. But essentially, the problems can be summarized as clinician engagement. So you need to find people like myself and Andy in every health board that are willing to give their time and engage with the project in order to get it up and running. The other thing you need to do is to have an IT setup locally that will allow it to be adopted. And that is actually much harder than it sounds. Excuse me. Because although we have 7 different health boards and we have something like Welsh Portal, which in theory is available everywhere, we have different health boards that actually do their own thing, have different teams working within them that may be more or less keen to engage in a project like this as we go along. Okay, next question. So there's a question from Sally Lewis. Hi Sally, I'm glad you're watching. She says, it's fantastic to see this data tool in use. How do you think we can engage more clinicians and other disciplines in regular use of tools like this to improve care and inform planning resources? Well, I guess the most obvious thing is days like today. I can see that there's been lots of people online, and hopefully more people will watch on catch up on demand. Because if people don't know that projects like this are possible, they're not going to get engaged. And certainly 7 years ago when I started as a consultant, although this was something that I wanted to do, I didn't necessarily have an idea of what it would look like when we got this far. So I think advertising goes a long way and engagement. But I also think you need a supportive technical team around you. And Andy and I keep saying it, but the Value and Health team really have been super helpful. Also, the digital team in Cardiff and Vale have been extremely helpful. And the other stakeholders in the original joint working agreement, that's DHCW, that's Welsh Government, that's the Wales Cancer Network, and that's Janssen, were all extremely helpful in getting this project off the ground. And the main thing is that one person can't achieve this on their own. You really do need a collaborative effort from all those kind of parties. Next question, you mentioned the high cost of drugs for myeloma. Are there any plans for adding costs into the dashboard to look at differences in treatment outcomes? I mean, well, if I were Chancellor of the Exchequer, that would be number 1, 2 and 3 on my list, but I'm not, thank God. We could do. I'm sure any pharmacists on the line would have an opinion about that, but if you really want to measure value in pounds and pence, that is actually what we should be doing. We have patients on treatments that can cost hundreds of thousands of pounds per year. And in terms of value, we're not necessarily obliged to measure anything. So I think that would be important, and I wouldn't be opposed to seeing it there. Next question, these data tools are great, and we need to introduce many more of them into our clinical areas. What are the important insights this data has highlighted for Dr. Bygrave, and have any service changes been made as a result of the data being analysed? Good question. What have I learned? I think I've learned that it's possible, and that's good to know. And I think also what I've learned is that there's 2 ways of going about this. If you want to do any kind of data project, you can basically do it retrospectively, and you can go in with usually some support behind you and say, okay, what sources of data do we have now and what can we do with them? And the problem with that is that there will always be gaps because no data system that we currently have is perfect. What we try to do with Haemabase and with the dashboard is to say, okay, we want to analyse the existing sorts of data like CANIS, like the admitted care record, like emergency department, etc. But we know that that isn't good enough because we know that there's still a lot of data up there that isn't being captured, and that's where the OCS and the MDT form comes in, because that's just making data available that has not been visible before. And so I think you actually need both approaches. I think retrospective projects are okay, but there will always be gaps because currently the NHS is not necessarily functioning in a fully technically literate fashion. Alan has a question. Hi, Alan. The dashboard might indicate variation in outcome across health boards. How do you determine, one, the variation is true, and two, if there is variation, is it warranted or unwarranted? Okay, I mean, that's a good question too. I guess you would have to look at what it's telling you and then go back to local clinicians and ask them if they think it's a fair reflection. So, for example, and apologies to anyone that lives in Cwmtaf, but do people diagnosed with myeloma in Cwmtaf generally not live as long with myeloma? Do they have run into more toxicities, more complications from treatment that make them not survive so long? You would have to probably cross-check your data with local experience on the ground, and I wouldn't be opposed to something like that. And then if there's variation, is it warranted or unwarranted? Well, yes, because there's no such thing as a perfect patient. And the problem with treating people for chronic cancers is they don't just come with the cancer. They come with everything else that they had before they were diagnosed, be that comorbidities, be that obesity, be that smoking, be that social deprivation. And so clinical trials will show you shiny data about pristine patients in clinical trials, but they don't really represent what goes on in the real world when you get a group of patients that come with all those toxicities. So when Andy showed you the slide or the bit of the dashboard that talks about comorbidities, for me that really is some of the most important data in it, because it's telling you that people don't just come with myeloma, they come with lots of other things. And I guess to answer Alan's question, if we had that feed from different health boards, then we could actually cross-check and say, okay, well, there's a ton more diabetes here, and that might be a reason why these people are doing worse, or they're getting more kidney failure, or etc. Has the team ever touched on using computer adaptive testing for PROMs? I'm going to make no apology for not knowing what computer adaptive testing is. Andy Simmons, does that mean anything to you?
Likewise, I feel like it should be something that I am au fait with, but it's a new terminology for myself.
Adaptive. Sorry, guys, I'm not picking that one up unless the author of that question wants to explain it. I might have to move on. Does this feed into a national registry or something similar? Well, two things. First of all, as a side piece from Haemato, we are about to enter into partnership with something called HONOR, which is a pan-European, Middle East and Asian myeloma registry that is also supported by Janssen. And what I would say is we wouldn't be in a position to do that, and we wouldn't have our data in good enough shape were it not for Haemato. So that is definitely an asset. And then the other thing is that there is also an English myeloma registry project that I'm part of, and they are collaborating with HEC, so the Health Economic Consortium in England, and they're definitely going at it in a retrospective way. So they're using HIC, sorry, it's HIC, Health Informatics Consortium, to retrospectively analyse data or data sources and answer questions like, you know, why do people from ethnic minorities not do so well, etc. But I'm part of that project, and once they're up and running and collecting, and perhaps collecting prospectively, then we would be able to share data from Wales with them and create something that is more UK focused. The quality of life measurement, do you use something myeloma specific or something more generic? Yes, there's a thing called MyPOS, which is a myeloma specific quality of life tool, and that's the one that has been taken forward and adopted by the National PROMS programme. It's been translated into Welsh and gone through all the other hoops before being launched, and as I said, we're about to get that available in the environment so that patients can complete it at home and then feed the data back into the dashboard. And I think that's all. I think that brings us to the end of the questions. So once again, thank you very much for your attention. Apologise for my coughing halfway through. If you've got anything to follow up with, you can get in touch with me or Andy by email or via the Value in Health team. We would be very happy to talk to anybody that's interested in our project and wants to do something similar. So thank you very much. Bye.